I'll make this relatively brief. It's going to be easy because lecture 18 I decided is a little bit too complicated for your level at the moment. Not putting you down, but I think I included too much material that's meant for year 3. So part B of lecture 18 will be totally deferred, but by all means review part A of lecture 18, the first 10 minutes or so, and I think you should be familiar with that. It just depends on how much you've covered on the Guyton family of cardiac function curves. So this lecture will deal with lectures 19 to 22, which is consolidation of cardiac catheter procedures, and lectures 23 and 24 are themselves revisions of the ECG and arrhythmias. And the last one on arrhythmias will be given by a guest lecturer, a cardiologist who specializes in EP. So hopefully he'll give you a different slant from it and maybe challenge you a little. So we'll move on. Lecture 19 covered catheters and guide wires. And again, I'm aware that many of you will have only covered lecture 19 and possibly not seen the others. And some of you may not have seen this lecture at all. So don't be put off by anything you see. It's not that complicated. This is an overview of the types of catheters used in the cath lab to engage coronary arteries. They're prefabricated in specific shapes to facilitate entry. And when you finally see one in action, you'll understand how cardiologists have to be familiar with the design and construction of all these different shapes to select the one that best suits their needs. They're extremely elaborate in their design, and their construction is very, very high-powered engineering. You'll appreciate that when you see them in action. In terms of their construction, they're not just hollow tubes. They're there to provide support, steerability, and be safe. We don't want to punch holes through the arteries. And you can see how the inner tube, called the liner, has a stainless steel cross-hatching braid that gives it, I guess, stability and provides control through the outside support jacket or sheath. Now, it's just useful to be aware of the design to understand how they can do what they've been designed to do. And the way to appreciate how they work is to have a look at the curves. They all come with a primary, secondary, and tertiary curve, and different companies have different designs. The idea is that the angle of takeoff and the length between the curves makes them ideally suited for one type of coronary artery or another. At this stage of your training, it's enough for you to be aware that different designs exist and different choices are made depending on the selection of the catheter that the cardiologist makes. In Australia, I have never physically inserted a catheter into a patient, but you're being trained to an international standard, as you know, and in some overseas laboratories, you will be trained in this. And hopefully you'll gain experience on it, also with right heart catheters. And you can see in this slide how that angulation is designed to push against one wall of the artery, providing tension against the other side, so that by manipulating the catheter at the outside end near the patient's groin, by twisting and pushing and twirling, the catheter can sit at the origin of the coronary artery. And you can see how the distance and the angle can make a difference depending on the nature of the lesion, such that a shorter curve can be useful for a higher orientation, and a longer curve may be more useful for a lower orientation. And to learn that, you just need practice and manipulation. That, as I said, I don't do in my role in my hospital, but others do in other institutions. And similarly with the guide wires, a catheter sometimes can get floppy like a loop of spaghetti, and the cardiologist loses control. When he does, he inserts a wire, which is more than just a thin coat hanger. You can see the design. It has an internal tapered core with kind of like a helical construction of a very fine wire forming a flexible structure on the outside. And you can see by the distance between each coil, it can give a twistability. And the distal tip has to be very soft and rounded to protect the inside of the vessel. Even so, we still have injuries and dissections. So that covers the basics of lecture 19. I think the lecture presentation itself covers it fairly thoroughly up to the level we need to go. Lecture 20 was pretty well self-explanatory. I deliberately focused on showing you moving images from the cath lab to illustrate how different procedures are done depending on what the pathology is. Now, you should all know what a ventriculogram is by now and be able to describe it. You should all know how to identify a coronary lesion. We haven't seen that many of them, but the intention is to identify whether a lesion is new and soft and friable that could rupture and cause a thrombus formation, whether it's an old lesion that's become calcific and requires specific treatment before it can be stented, or whether it's a chronic stable occlusion that will be not impossible, but extremely difficult to dilate. Similarly, we went through a history of the procedures in terms of balloons, how they're used. You've seen a few simple shots of balloons in action, and stents. The two main types of stents are bare metal stents and drug-eluting stents that we'll hear more about in later lectures. I didn't show you much in the way of saphenous vein grafts and a specific one for the left internal mammary artery because those runs are very long. They take up memory. I might consider putting in a little mini tutorial showing you some lengthy AVIs before your exams. It'll be useful. And valve pathology and cardiomyopathies dominate a big part of our life in the cath lab. They're illustrated in the lecture, and I think they're all self-explanatory. We also cover the different types of diagnostic and interventional procedures in the cath lab. You all should know by now we do both left heart studies and right heart studies, depending on the presentation. For example, for a heart transplant assessment, it's an involved physiological study. Coronary artery disease is just a left heart catheterization investigating specific lesions. We diagnose and treat STEMIs, acute infarctions, or pre-existing infarctions. We treat these conditions, coronary artery disease, with stents. And again, cardiomyopathy and valves, that's a big part of our cath lab life. We need to know how to diagnose them. We can't do much for treatment of cardiomyopathies in the lab, but we do treat valves. In fact, we replace valves, and that will dominate a big chunk of third-year courses. There are different types of pericarditis. We can investigate. We can't really treat them, but we are a big part of the diagnosis. Structural heart interventions are still relatively new, and they're growing. We do peripheral treatment of vessels, stents in the renal arteries, in even the femoral arteries, and as you've seen, in carotids. We do a lot of congenital defect analysis, and you'll come across that in great detail in your echo life. And we participate in clinical trials, which is also heavily integrated with echo. That is a growing list, in fact. Every year we have to add another list, and there's more that I haven't mentioned, just briefly. To illustrate how grafts, bypass grafts that are inserted traditionally by a Black & Decker through the chest wall to expose the root of the aorta, you can see here how if you have a blockage in a coronary artery, you can make a little incision at the base of the aorta and take a vein that's usually been taken from the saphenous vein that is translocated and sutured into the aorta to bypass the narrowing and is sutured distally into the affected coronary artery. Traditionally, we use saphenous vein grafts that are veins filling the role of a artery, so they have a limited lifespan. 10 years is good, 20 years is outstanding. Lately, we take radial artery grafts. We dissect out a section of the radial artery in your arm, leaving the ulna to provide circulation, and they serve the function of an artery, replacing an artery, and so they're longer lasting. We also have the right internal and the left internal mammary arteries that are simply snipped off the chest wall and relocated to a coronary artery. They're functionally much more long-lasting, technically a little easier, I guess, in that you only have to suture one end of the lemma or the rema to the part of the coronary artery that you're bypassing, and you can even have a separate conduit, say from a radial artery, to go to a region that is too far away for the lemma or rema to reach. The lemma is used for the left side of the heart, and the rema is used for the right side of the heart. The rema is used for the right side of the heart. I think this drawing is very good, so you should appreciate how that works. Now, Cath lab populations are full of sick people with a lot of comorbidities. And in this term, we're not really investigating too much pathology. We're trying to understand normality, but you need to understand a lot of the pathology and how it interacts with the disease patterns we see in the cath lab. And again, this slide I could not edit to make the yellow writing more clear. I have to find the original slide I used that I created and change that writing. But bear with me. These are risk factors or comorbidities that patients present with. And just to cut the story short, this is representative of the general population in a study that we did, and this is representative of a cath lab population. And you can see for a cath lab, the population is 69% male in this study, and in our group it was 71%. So we'll just run this breakdown, they're very similar. Smokers, 43% here, 59% there. Patients with hypertension, 68% in this group, 59% in that group. Patients presenting with pre-existing coronary artery disease, 35% versus 48%. Sorry, this group is post-infarction. So this represents roughly a different population, but we had patients with pre-existing coronary disease as opposed to patients with previous myocardial infarction. Post-bypass grafts, this population had 18, we had 14. Diabetes, our population had 21%, this population had 24%. And this is a small group that was included as part of this study, which had previous brachytherapy, that's a discontinued practice, radiation treatment for coronary artery disease, not successful. And I've added here for our group, 30% had a family history of coronary artery disease and 50% had high cholesterol. All these pre-existing conditions or comorbidities or risk factors make for a sick patient population. And I compared this to an article published that showed for the general population over 65, 65% had arthritis, 37% had hypertension, 12% had pre-existing heart disease, consistent with this, I guess, bypass group of 14%, a post-infarction, much higher, and diabetes mellitus, 12%, and dementia, 4%. Now you wonder why these percentages are lower for this population over 65. All I can say by way of explanation is that if you're over 65, you've survived a big part of the age group that dies from cardiovascular disease. There are two main age groups that die from cardiovascular disorders, heart attacks. That's in your 40s, and again in your 60s and 70s when it kills most of us. So the populations aren't consistent, but it emphasizes my point. You're going to be dealing with sick people in the lab, and these comorbidities you should be familiar with. Make it a point sometime in your time this year to find out what diabetes does, what hypertension does, what smoking does, and understand some of these pathologies involved. Now, going on to lecture 21, coronary artery disease, treatment of. I went through a bit of history and how we treat it. And the biggest breakthrough was the development of the balloon dilatation of a lesion and the insertion of a stent. Before that, patients were given aspirin after a heart attack, and they either lived or they died, or they went on to have bypass surgery. This avoided bypass surgery. You stick a catheter across the narrowed lesion or occluded lesion, inflate it, squash the occlusion out of the way, and deploy a stent, which I show you here. And that's what they look like. They're crimped on a balloon, they're expanded by the balloon, and finally, with optimal expansion, those little struts bite into the wall of the artery. Now, there was a problem with stents originally, in that you're introducing a foreign body into the coronary artery, and that causes a prothrombotic environment that can rethrombose in the short term with a clot, or the simple process of healing can cause thickening of the coronary arterial wall, which causes a re-narrowing of the artery. I go through this in a little detail in the lecture presentation, but these illustrations show very nicely how the narrowing of a thickened vessel can obstruct blood flow, causing ischemia and chest pain. And if it occludes sufficiently, it closes off and you have a heart attack. The problem with a stent, a drug-eluting stent, was that they were coated with a drug called paclitaxel or sirolimus. One of them was a cytotoxic drug and the other one was a cytostatic drug. The lecture explains the differences. But what happened was, in an attempt to prevent this thickening, this cell proliferation that was part of the healing process, they prevented the natural endothelial process that would cover the bare elements, the struts of the stent. So you had a chronic thrombotic environment, meaning it attracted platelets. And short-term in-stent restenosis was a major problem, such that they questioned the value of a drug-eluting stents. What they needed to do was introduce antiplatelet agents for a longer period. And introducing these antiplatelet agents, which prevented platelets from aggregating and causing a thrombus, solved the problem. The history of stents and drug-eluting stents is quite fascinating, because it was a powerful treatment that really they should have done more testing on. The major advances in PCI, again, it's more for general knowledge, but you need to be aware of all this in your professions. Balloon angioplasty, PTCA, proximal transluminal coronary angioplasty, followed by stent deployment with bare metal stents, BMC, or drug-eluting stents. Sorry, that should be a BMS. Apologies. The two drugs that came to the fore after introduction of the drug-eluting stents were paclitaxel, cytostatic drug, and sirolimus, cytotoxic. Sorry, paclitaxel, cytotoxic, sirolimus, cytostatic. One kills the cells, the other one simply arrests the development. This one worked better and is the one in wider use, although paclitaxel still has a place. Using double antiplatelet therapy solved a lot of the problems, and patients are now on antiplatelet agents for long-term periods, like 12 months. New drugs were introduced for that. And a drug-eluting balloon is now coming to the fore, where the balloon has the drugs that are diffused into the wall of the artery, and they take over the role of the drug-eluting chemicals in the stents. We haven't used them in my unit, so I'm limited in my experience of that, but other labs are coming to the fore with that. And the next step is have dissolvable struts. So instead of leaving a metallic structure that needs to endothelialize, and that can take a couple of years, so you have to be on your antiplatelets for maybe up to that long, they eventually dissolve and you have a virgin vessel left intact, which has its own benefits. In the lecture, I discussed the other types of ancillary procedures that we can do that are difficult to explain until you see them. Atherectomy, which slices parts of the thickened wall, particularly with calcium, that needs to be removed. And a rotoblader has a similar effect. It's a spinning little microscopic particles of diamond dust that breaks up the plaque containing calcium that will not distend into small chunks that can be squashed. Again, you need to see these, and you will see them in your cath lab placements. Just be aware that a procedure is called atherectomy, rotoblader, laser technology has come and gone, and brachytherapy has come and gone. And the instruments you will be exposed to that everybody wants you to learn in your career is intracoronary ultrasound, intravascular ultrasound, and fractional flow reserve, which are functional studies of blood flow that assist in evaluating the stent procedures. The E here stands for echocardiography. We just think of it as ultrasound. So we're nearing the end of this tut. This is an illustration you've seen before showing you some of the different devices you will use in your career. We will be taught, or we will learn how to use each one of these in turn. Don't be frightened of them. Everything is easy once you learn it. And the last lecture that we're discussing is lecture 22. We're making good time. Cardiovascular hemodynamics. And in this lecture, I present how to analyze different waveform components to diagnose valve stenosis And I introduced different types of gradients, which you will see in echo, particularly the peak-to-peak gradients, to measure the severity of aortic stenosis. And I introduced the concept of time lag effects. They're just names. They're pretty simple to follow. This is a trace you've seen before of a catheter in a ventricle pulling back to the aorta. And you can see that the systolic value of the aorta and the ventricle are the same. That's what happens in a normal valve. According to Pascal's law of partial pressures, pressures equalize in two different chambers, provided there is continuity of flow. If the valve is open, during systole, which is what happens with the aortic valve, there is equalization of pressures in both sides of that valve, meaning the ventricle and the aorta during systole. And this is a patient in sinus rhythm and an almost perfect equalization of pressures in aorta, in systole. This is an example where a patient had an ectopic and he's a little more tachycardic. They're both in sinus rhythm. But you can see that the average systolic value before the pullback across the aortic valve, which is this point, you can see the change in pressure between a ventricular trace and an aortic trace. You still have the same systolic value. So in spite of artifact, you can still diagnose a normal aortic valve, or more correctly, a non-stenosed aortic valve. You'll see that almost with every case in the cath lab. What happens though with a stenosed valve? We diagnose that in the cath lab, apart from simply listening to a murmur and having had an echo. You can diagnose this by echo, as you might know already. When you do a pullback, there is a pressure gradient between the ventricle and the aorta. And it can be measured as a peak-to-peak gradient, simply the difference between one systole and another, or as a mean gradient, where you overlay one ventricular beat over an aortic beat, and the integral of the difference between the two curves is mathematically equivalent to the area between the two curves. And the computer calculates that and reports it as the mean aortic valve gradient. Now, why is there a pressure gradient to begin with? Think of a room separated from another room by a door. When you close that door, there are two independent chambers, and each can have its own pressure. You can pressurize one side without affecting the other. But if one side is pressurized, think of the ventricle as being pressurized because it's hypertrophied with a high systolic pressure, and it's hypertrophied as a result of a narrowed valve. When that door is opened, the ventricle has to push with greater force to pump that same volume of blood across a narrowing. So it develops a greater pressure over time. But when that valve is open, on the other side of that valve, the aortic pressure is the same. So that when the door is closed, the pressures are different. If the valve were normal, the pressures are the same. But with a stenosed valve, when that valve is closed, the ventricle can generate a much bigger head of steam, a much bigger amount of pressure, a greater amount of force that is independent of the pressure on the other side of that valve, which is the aorta. The aorta does not have to do anything to compensate for that aortic stenosis. Now, that is simply physics. The reason the ventricular pressure is elevated is that the ventricle has had to hypertrophy to generate greater force to force the same volume of blood through a narrowing. And we measure that difference in force as a pressure gradient across that valve. And we measure it as a peak-to-peak gradient or a mean gradient. There are different ways of measuring that pressure. The easiest way is to do a pullback, as you saw before, but you can also have two catheters, one in the ventricle and one in the aorta. And this aortic trace is the same trace. And the ventricular trace shows you the pressure gradient with a catheter in the aorta simultaneously as in the ventricle, as opposed to a catheter in the ventricle that's just being pulled back on its own. And you can see how the ventricular pressure, once it crosses to the aorta, becomes an aortic pressure trace. You've crossed that valve and both catheters are now in the aorta. That gives you simultaneous beats. Instead of just picking any beat at random in the ventricle and superimposing it with any beat at random with the aorta, you can measure that mean gradient individually for every beat, which is a little bit more accurate. And this shows you how we can do that. So we can measure each individual peak to peak and average them all, or we can measure each individual mean gradient and average it. Now, this is a slightly different trace in that instead of the second catheter being in the aorta, the second catheter is in the femoral artery, so that you don't need a second catheter. You can just use the introducer sheath. And the difference between the systole in the ventricle and systole in the femoral artery is a reasonably accurate measure of the aortic stenosis. These are two different patients. This is a patient with a ventricular trace in the ventricle and the aortic trace being substituted by the femoral artery. This is for a patient with aortic stenosis. This is for a patient without aortic stenosis. So you can see that the ventricle and the femoral artery have the same systolic value. So that allows you to use this as an estimate of aortic stenosis without having to use a dual lumen catheter or having a catheter in the aorta. But there are limitations because this is a patient where, I confused the two slides, it's a catheter in the ventricle and a pressure connected to the transducer from the sheath. You then pull that back, and you can see that when the ventricular trace comes across to the other side of the aorta, one of these pressures is aortic and one is femoral. They're color-coded in real life. The printout was only in black and white, but you can see that aorta and femoral artery are slightly different. We call this the intrinsic gradient between the aorta and the femoral artery. So, if you're using the femoral artery as a surrogate for aortic pressure, as in this case, consider this. If, in this case, it doesn't matter which, but let's assume the higher pressure is the femoral artery. If the femoral artery is greater than the aorta, then you're not measuring the true difference across the aortic valve. If we assume, say, the ventricle is 200 and the femoral artery in this case is 160 and the aorta is 150, then the true gradient is between the ventricle and the aorta, which is 50 millimeters mercury. But if you're measuring the femoral artery trace and that femoral artery is 160, the gradient you're measuring here is only 40. So if the femoral artery pressure is greater than the aorta, and you can establish that after the pullback, then you have to add that 10 millimeter difference between the two to get the true gradient. If, on the other hand, the femoral artery is lower than the aorta, let's reverse the pressures here and say the higher is aortic and the lower is femoral, then you subtract the difference because you're measuring the difference between the left ventricle systole and the femoral artery, but the femoral artery is falsely low. So you're exaggerating the gradient. So you have to subtract that difference to get the two. It can be confusing. I know we're tight for time. I've only got a few minutes to go, but if you do that for yourselves, if you draw a ventricular trace, then a femoral artery trace, and then an aortic trace, just do that on your own, and I'm sure it'll become clear. And if not, the lecture explains it reasonably well too. So there are three gradients. I've shown you two. I've shown you the peak-to-peak gradient, which is C, differences in systole. I've shown you the mean gradient, which is the area between the two curves. What you measure in echo is neither one of those two. You measure the difference between the aortic pressure and the ventricular pressure indirectly by measuring the instantaneous peak flow gradient through Doppler analysis. And what that gives you is the difference in pressure between this point and that point, the point of peak flow. It's not perfect on this graph. It could be a little lower, it could be a little higher, but your peak flow velocity out of your ventricle occurs somewhere in this point. And that is the jet of blood that you measure with echo. And the echo machine calculates that value. And that is a measure of the severity of the aortic stenosis, and is called the instantaneous peak flow gradient. It's just that it's going to be different from the peak-to-peak gradient in the catheter and from the mean gradient in the cardiac cath lab. And this is still a valid measurement, but it's a non-invasive measurement that is still useful. And very often, that's all you have. But it's something you will have to learn using your Doppler color flow analysis. Just be aware there are 3 different ones. Just know how each one is arrived at. One is simply the difference between systoles. One is the area between the 2 curves. And one is derived from a formula in your machine that gives you that value, the pressure difference using the peak flow velocity gradient. This is the last slide, and it's simply the inverse of aortic stenosis. We can have mitral valve stenosis in the same way that you can have a systolic equalization for the aortic valve. The mitral valve is open in diastole. So when the mitral valve is open, pressure in the end diastolic pressure of the ventricle and the left atrium are the same. And if you look at this particular spot, the A wave in the end diastolic pressure of the ventricle is exactly the same as the A wave in the left atrial pressure. And I've said before that in the left atrium, the V wave here is paired with the A wave. The A wave is paired with the immediately preceding V wave, and that is why these two share the same beat, the same ventricular diastolic equivalent. The important thing is these pressures are equalized in diastole. Here I've just shown you the A wave and the V wave. And a normal valve has a valve area of around 4.5. That's the nose valve that has an area of about 1 centimeter squared, 1 centimeter squared. If you have a stenotic mitral valve, exactly the same situation exists as with an aortic valve, except it occurs in diastole. And what happens is the atrium has to pump a greater amount of force, or the left atrium has to pump the blood through with a greater amount of force to force the same volume of blood through that narrowing, the same open door principle. Except in this case, it's in diastole. And when that door is narrowed, the poor old atrium, when it contracts with its atrial kick, has to contract much more strongly to force the same volume of blood into the ventricle. And that gives us a diastolic pressure gradient. If you turn this slide upside down, you'll see that the difference here is sort of similar to the difference between the left ventricular pressure in systole and the aortic pressure in systole, except we're looking at the opposite end. In diastole, we're looking at the diastolic pressures. That can be difficult to appreciate, but there's little you can do except read a little more, or hopefully understand it better from my actual lectures. And remember, this is a tutorial that's not covering everything in my lectures. It's a selection of slides to prepare you for the lectures so you know what to anticipate and hopefully to understand it a little better. So I'm leaving that here. Remember that cath lab pathologies are investigated frequently by both echo and cardiac catheterization, along with other modalities, MRI, CT, CA. And next year in particular, you will need to understand your cardiovascular pathology, and that will depend largely on performing your own studies. I'm trying to teach you things from slides that really you will only appreciate in full when you see them done in a lab or when you do them yourselves on real patients with real pathologies. I encourage you, not just between now and your exams, but afterwards, during your holidays for the rest of the year, read widely. Make sure you've read all the references I've given you. Go onto sites online and try to read more. And when you're in the hospitals, participate in studies and view these activities in different units. So with that, I'll end this session and wish you all the very best in the exams that are coming up. I will stop sharing and see if there are any questions, although I know that Sharon will be here soon. So, any questions? Can you all see me and hear me? By all means, go onto voice and ask. Or type if you prefer. Either way, I will end the meeting in another 30 seconds.
Can we send you emails with questions over the term break?
By all means, any questions you send, I will either answer directly or I will organize a mini tutorial if I think it requires a lengthy explanation. More than happy to do so, Lily, and that applies to anybody else, of course.
Thank you.
It's good if you share the answers with your own group. That would be very good.
Yeah.
All happy? All good? All the very best with everything, and we'll hopefully meet you at some stage. And if not, I hope to see every one of you in year 3. My term will be occupied with year 1 students for the rest of the year and preparing lectures for you for next year. Ciao, everyone.
Ciao.